One of the greatest parts of cash pay is that high deductible health plans are really common. I have a $5,000 deductible. Not really, but
right.
Hypothetically, I have a $5,000 deductible, and I'm a really healthy person, and I don't really expect to meet that deductible, and I need to go to urgent care, and the cash pay price is $150. But my insurance may apply $1,000 to that visit. Why would I not pay $150 if I don't think that I'm ever going to reach my deductible?
Welcome to ClaimTalk. I'm your host, Danielle Young, and today we're going to be discussing a very important topic around cash pay. Cash pay is a term that we use to describe when patients go into a doctor's office or a facility and decide to utilize cash as their form of reimbursement, as opposed to perhaps an insurance policy or a direct contract. It is becoming more and more common, but when it comes to healthcare, is cash really king? I don't know. We're going to discuss that today. I have two lovely guests with me who I will allow to introduce themselves. Let's go ahead and start with you, Leah.
Hi, everyone. I'm Leah DeBartolo. I'm an account coordinator here with ClaimTalk. I have been with ClaimTalk since April 2021, and my main role here is working with groups as account manager and help implementing new groups onto the plan with ClaimTalk.
And my name is Amy Pellegrin, Senior Vice President and Chief Legal Officer.
Thank you so much for being here, and I'm so excited for the audience and listeners to get to hear your expertise. Because I am an established and well-known nerd, I always have to start with a little bit of history around cash pay. So when we look at the American medical landscape, about 100 years ago in 1925, hospitals were starting to systemize, were starting to become more elite. They were becoming a little bit more of a preferred place to get treated. Prior to the 1920s, hospitals were generally places where you would only be if you were poor, sick, or mentally impaired. So they were really more charity organizations, typically funded by religious organizations. Politicians, generous benefactors would put money into hospitals so that people who could not pay cash for a private doctor back in that time would have the ability to at least be comfortable, if not perhaps get a little bit of adequate medical treatment. So that was 100 years ago. So you fast forward 100 years, and now we're in an environment where most hospitals are part of a system because they've started to sort of group together with collective bargaining and all other sorts of things that come with that massive power. But subsequently, most hospitals prefer to take reimbursement from an insurance company or through a direct contract where they have pre-negotiated a price. And because of that, cash isn't always king. Money's not always green at a hospital system because they would prefer to be paid on those health insurance reimbursement contracts. Of course, over that 100 years, lots of other things happened when it comes to reimbursement and how we pay for healthcare and all of that type of stuff. One of which includes the time after World War II, where employee benefits became more popular. There's lots of steps on the road. But I want to sort of circle back and get both of your perspective on where cash pay sits today, and maybe even if you have a little bit of historical context as to how we got here. Do you want to kick us off, Amy?
Sure. I think that the cash pay solution has been a challenge for a lot of the providers and facilities historically once the network environment became so popular. So providers and facilities are engaging in network contracts, and the reality of that is they feel like they need to operate within the corners of that document. Fairly so. But where that challenges the providers and facilities is that you've got patients that have insurance benefits and they feel this obligation to use those benefits. And by they, I mean the providers and facilities. And so the conversation of, is there a less expensive option for me, just doesn't exist. And as a result, we've actually seen a lot of providers and facilities refuse to extend other payment opportunities to those that present insurance. And so patients are then left with their insurance benefits, which they usually want to use because they aren't necessarily educated otherwise. And providers have become accustomed to submitting claims when in reality, there are other options for fast payment at the time of service that maybe patients should want to explore more. And it's becoming more common that providers are offering that opportunity to the patients.
Leah, do you mind sharing with us a little bit what you find in terms of how cash payment sits relative to maybe contract or direct contract payments in your experience?
So for the cash payments, what we've seen is typically that the providers, if they do offer the cash pay, which most of the times they would call it a self-pay discount to the members, is significantly less. I have seen a provider where they offer 50% discount with an additional 20% discount if paid within a certain time. So it is way less than what it would be if they just accepted the insurance and submitted it, or if it is a contracted rate.
And I like to clarify that you said cash or self-pay is typically how they refer to it.
Yes.
Which I think is an interesting distinction, because I think self-pay and cash, obviously we understand to mean the same thing. But I think when providers see self-pay versus insurance, they see the self-pay and they're maybe a little bit more gentle to that price point. Do you think that's fair to say?
I think that one of the other terms we need to throw out there is uninsured. When you're uninsured, you are also self-pay, right? Because you don't have insurance. But at the same time, then you may qualify for certain other programs with the hospital or provider. So one of the challenges I think we face quite often is we do have some provider relations that do not want to apply self-pay if there's an insurance benefit because they're concerned about their policies related to the uninsured. So that's a third term I'd throw out there that does complicate the landscape for the provider community. But at the same time, that self-pay does become a cash payment form. So there are some distinctions when you're talking to a provider. They don't always make business sense as to why they may or may not apply that self-pay option for a patient.
So when you mentioned that the term uninsured matters to a provider, does that relate to the percentage of care per year they're required to give as a not-for-profit, or am I down a wrong rabbit hole there?
Each hospital, not necessarily a provider, but each hospital that participates in Medicare and Medicaid would be required to have certain policies in place as to how they treat patients that may need financial assistance. And that's also related to their nonprofit status. And so when you're uninsured, those would be automatically applied. And when you have insurance, they typically still need to offer those opportunities to the patient, but they want to make sure they're not discriminatory in how they treat their patients. And so they attempt to use some sort of consistent approach. While I don't necessarily agree that a patient's choice whether to use their insurance or not should change those policy applications, we do see that get complex with those conversations because some providers do take the approach that if they treat an insured patient like an uninsured patient, that may present them with challenges.
Interesting. Do you mind elaborating on maybe the biggest challenge that they're concerned with by treating an insured patient as a cash pay, self-insured, uninsured?
So I think there's a couple angles there. One of the things that we see pretty regularly is that if a provider categorizes a patient as insured, they may take the approach that they have to treat them as insured, meaning they have to process that claim through insurance. While that sounds beneficial to the patient, it isn't always, as we'll probably get to later as far as the benefits of cash pay and why a patient may not want to use their benefits. But it comes back to that earlier comment I made about the network environment and how providers are so ingrained in the network arrangement that they have these contracts. And those contracts typically say you can't negotiate the patient's benefits. So if you're working with a patient outside of the claims processing world, then could you arguably be affecting their out-of-pocket? Or is the patient potentially self-submitting the claim on the back end, getting credit for their accumulators? And is that some sort of negotiation as well that would be out of compliance with the network arrangement?
Yeah, that makes sense. So I want to back up a little bit and talk about why at ClaimTalk we are discussing cash pay and why it's become more of a prevalent conversation. So occasionally what will have happen to us at ClaimTalk is we'll have a patient that walks into a provider or a facility and their facility will not accept their payment plan. They don't want to participate with our program. And so subsequently what we might do is offer the facility cash instead of participating in our program because they perhaps don't recognize our program as true insurance, or they have maybe issues with the reimbursement schedule or whatever the case may be. We've historically used a cash pay opportunity to still gain access for the member to get into the facility or the provider, and still obviously reimburse the provider or facility at a rate that we all deem acceptable. So in that spirit, why don't you talk a little bit about MedCash, Leah, which has been our historical solution for this problem?
Yeah, so MedCash has been our cash pay solution that we have engaged for the members who, if they do have appointments and they go and the provider does essentially not want to submit to their insurance, or I'll circle back to the provider with that heavy discount. They chose not to recognize the member's plan. So that one specifically, we engaged MedCash for a solution for the member so that way they could move forward with their appointment due to us asking the provider if they offer self-pay discounts. We recognized that they do offer the self-pay discount, and it was 50% with an additional 20% if it was paid within an additional time frame. I believe it was 30 days after the date of service, so quick turnaround, but a heavy discount from the original billed charges. From there, we worked with the member to gather all of the information ahead of time, everything that would be done for the procedure, so that way we could get the final dollar amount and get that paid to the provider. Once we got the provider paid, the appointment moved right along. The member was able to show up with no issues at time of check-in, and procedure happened. After that, we were able to get the itemized bill, sometimes called the super bill, for the member, and we worked with the member to complete their claim form, and they submitted it off to their TPA for processing, so that way it would go through their benefits. And then once the EOB was generated, we did see that there was some additional payment owed, so we were able to get that payment off to the provider within that time frame for that additional 20% discount.
So is this an automated process?
The members never left alone, wondering what comes next, how long it's going to take. Once we identify that a cash pay solution is going to come to fruition and it's going to be the best option for the member, we work with that member to get everything ahead of time. So either a good faith estimate, or if they know the exact charges, we get that information. We work with the member to ensure that they know if they need to make a certain payment ahead of time, or if they should just wait until afterwards to make a payment.
When we say cash pay, there's this vision of you walk in, hi, I need a knee replacement. Here's your $40,000. I'm going to go back and have that done real quick and I'll see you later. Especially the way that we're working through it with our members. Mm-hmm. It's incredibly ingratiated.
And I think you make a good point there. There are plenty of cash pay solutions, which are maybe a prepaid credit card, usually in some form of a physical card that the member may have pre-filled. And those are really helpful for office visits, low-cost scenarios. But when an employer is being subjected to a high-cost surgery or other service and the patient, you don't want your members having a pre-filled card for $40,000.
No.
You want there to still be a vetting process, and the patient also will not have that sort of cash to come up with up front. So while there's a significant discount and advantages to go through that process for the patient and the provider, a lot of those cash-based solutions that we hear about on the market may not be able to accommodate a surgical procedure or a high-dollar situation. I mean, we've definitely seen cash-pay situations that we've created access or seen the deeper discount that are, over 6 digits.
Yes.
And so this is not just your typical office visit where a pre-filled, card with $500 is going to be sufficient.
Yeah, can you share with us, Leah, some of the examples of the types of procedures that we've used MedCash for?
Certainly. We did have one where a member was unfortunately diagnosed with an aggressive form of cancer. And of course, getting that diagnosis is not good. Any age, any person, any family member, you don't want that diagnosis. So just to be sure, this member wanted a second opinion just to confirm that diagnosis, so that way they would know treatment plan, outlook, prognosis. Unfortunately, the provider that the member chose to do the second opinion, it was outside of plan guidelines, which for plan guidelines is 300% of Medicare. We did try working contract contract negotiations, but that fell through as the contract negotiations, again, were outside of plan guidelines. So that from there kind of reverted to utilizing the cash pay solution and bringing that in to see if it was possible. From there, we got all of the information ahead of time. We were able to work with the provider as they did offer a self-pay discount. It wasn't a huge discount, but it was a discount and it assisted the member in being seen. We worked with the provider to get that payment to the provider so that way the appointment could still happen. The member could go get what was needed done. Unfortunately, the diagnosis did come true. The second opinion did confirm the diagnosis. So looking back at it, it was good that we were able to engage the MedCash solution in it. So that way it could give the member, that confirmation. On our end, we were really hoping that diagnosis wasn't true, that it may have just been a misdiagnosis. But we were able to get the member in, and from there, the member was able to kind of step back, realize, and decide a treatment plan on what to do next.
Yeah, when they might not have otherwise had the access to that second opinion that they were hoping to get. And I know, Leah, you and I have talked previously about the fact that we have different parameters. Amy, do you want to give us some thought about the parameters that we put around our solution and maybe why they're there?
Sure. All of our clients are self-funded ERISA clients, and so there needs to be specific direction for the plan in how they meet their fiduciary obligations. And our program specifies the reimbursement that is appropriate and reasonable using fair benchmarks that are industry standard. And in doing so, we also recognize where that limit is, where at some point those numbers become egregious, and help guide the plan sponsors in determining how they should prudently manage their plan assets. And in doing so, the benchmark that we use is 300% of Medicare. There are situations where a plan may choose to exceed the 300% of Medicare. Maybe it's specialized care that is unavailable other places, continuation of care. There are a number of reasons why there may be a non-discriminatory exception that could be made, but this allows for consistent and non-arbitrary application of the plan benefits to the participants.
And non-discriminatory as well.
Correct.
Right. Yeah. Good. Thank you. Thank you for that clarification. As you mentioned, sometimes facilities or hospital systems providers may not be as amenable to cash pay if they believe there is an insurance on the back end for a myriad of reasons. There isn't necessarily just one. Like if you go in and you are insured and you say, I want a cash pay, is that actively committing insurance fraud?
No.
Just
That's
to be
the
clear.
simple answer. Should we stop there? No. The big F word, fraud.
It's scary, right? So it makes people
I always try to put myself in the perspective of the provider. If we understand where they're coming from, maybe we know how to create the solution a little bit better. Definitely not fraud, right? Fraud would be submitting a false claim to insurance. I think one of the things that often gets overlooked and is frustrating from our perspective when a provider who I'm sure in good faith is trying to be non-discriminatory and treat patients consistently claims that they have to comply with a certain process of, if you say you have insurance, we have to process it through insurance. I would love to have a conversation with anybody at a health system to better understand that position. But an employer's health benefit is a relationship with the employee. And the only way the healthcare provider is even involved in that is if the employee offers to give them an assignment of those benefits.
Which they would not do.
So they're my benefits. They're your benefits.
They're not hospital A's.
There's
benefits.
No connection to the urgent care clinic unless the employee chooses to provide that connection through the assignment of benefits.
Is that something any prudent person would do? Is that a thing that people do? Assign their benefits to an urgent care?
Yeah.
That is.
This would be a standard practice for any insurance process, any claim. When you go into the doctor's office, they do not have rights to receive payment from your insurance company without getting that assignment.
I got it. Okay.
So it's sometimes called an AOB. It is a legal term, but we all sign them every time we do submit our insurance. They're very common. But that is the only link that the healthcare provider has to those benefits. So interfering or stating that they don't have the ability to process something outside of insurance if they know you have insurance is just factually wrong. I mean, you have the ability to choose whether to use your benefits or not. I think that one of the greatest parts of cash pay is that high deductible health plans are really common. I have a $5,000 deductible. Not really, but
Right.
Hypothetically, I have a $5,000 deductible and I'm a really healthy person and I don't really expect to meet that deductible and I need to go to urgent care and the cash pay price is $150. But my insurance may apply $1,000 to that visit. Why would I not pay $150 if I don't think that I'm ever going to reach my deductible? There's just a lot of reasons why a patient as a consumer is going to choose a cash pay. I think a lot of our patients, our members don't recognize that opportunity, but it's becoming more common. It's becoming more common with the Transparency Act and providers becoming more comfortable with the cash pay option. But to take the position that the member who has the benefits doesn't have a choice whether they get to use them or not is an incorrect understanding and application of how the benefits interact with the healthcare provider. And I think I know where that narrative comes from, and that would be if I had a major network and I went in and did cash pay, and then I turned around and self-submitted the claim. I still don't think that would be considered insurance fraud. Again, that's a big F word. That's a very loaded statement. But from the provider's perspective, they may view it as an inaccurate representation of a health claim because they did not process it through the contract that the network is under. Again, it's an overstatement to say that, but I think that those misunderstandings or those processes that are frankly unfair to the patients are ingrained in that network environment that we are just so accustomed to that it's really hard to transition out of it. But I do think that with the Transparency Act, we're seeing new processes and opportunities where providers are seeing this as an opportunity. In fact, not only is there federal law about posting cash pay, but a lot of states are also enacting state-specific laws that require providers post those cash pay discounts. And a step further to address that situation that you even described, we have some states who are recognizing this oddity of, I don't think I can offer this cash pay because this person has insurance, and are specifically legislating that they are required to offer it or have to be willing to accept it from the patient. So it is a problem. It is a situation that exists with providers and facilities, and there are states that are attempting to rectify that.
Yeah, I know with a client, and I think it's so interesting that we have to get legislation involved to get people to do the right thing. That's always been a frustration of mine. But I do think it's interesting, too, that there has been such pushback, because you would think because of the speed of a cash pay that a facility would be more likely to engage in it. Do you think that there's a particular rub with the RBP? You mentioned this earlier, Leah, like if someone's just like RBP yuck, do you think that ick is a little bit of what we see around the obstructionism around cash pay?
Yeah, so that I'll go back to that one. It was a specific provider that did see RBP in a negative light, saying, nope, we're not going to submit to your plan. We won't see you. That's where we from there, we pushed back with the member, asking if there was a self-pay discount. And then that's when the provider happily said, here's a 50% self-pay discount. If it's paid within 30 days, it's an additional 20% off of that. So from there, we were able to go that route and engage. The provider, thankfully, took that self-pay amount, didn't question anything. The member did go to the appointment. It was a pretty important procedure for the member to get done. And then afterwards, again, help them get the itemized bill, get the claim form sent off. They did self-submit the claim to their TPA for the benefits to apply. And then once the EOB or explanation of benefit came back, they did have some additional patient responsibility that they turned around and paid the provider. From there, they have done a few other, I've seen a few other cash pay themselves, not necessarily engaging MedCash because that procedure was a high dollar amount, but they did it themselves once they were educated to ask for that self-pay discount.
That's a really interesting outcome I would not have expected.
Yes.
That's interesting that because they saw how the mousetrap was built,
Yes,
they had the confidence then themselves to go on a lower dollar amount. That's interesting. Another thing I thought that's interesting about that 50% off and then 20% off if you pay it within 30 days, it just reinforces the point you were making earlier that really what interests them is getting paid quickly. It's not 100% or 50%. They're like, hey, I'll come down to 30 if you'll pay me within 30 days.
yes.
I mean, that incentive is huge for them, for the facility, for the provider. So you would think that cash pay would be a little bit more acceptable or become a little bit more popularized. What do you think the challenges there? Is it just the RBP big scary or?
I don't think it's limited to RBP by any means. I do think that certain health systems that have taken a stance are attempting to create obstacles that don't allow access a different way. Whether that's right or wrong, especially for nonprofit charitable organizations, is probably another conversation. But I do think there are realities in those health systems that are challenges. Just the collection of payment. They usually don't have mechanisms. If you think about checking into your doctor's office, you don't see them accepting cash, literally cash.
There's not even like a point of sale at the front desk.
Yeah.
Like a little system.
Exactly.
Yeah, right.
There may be, but often they are designed to collect those copay deductibles if they have a policy for that. But you will rarely see somebody have a mechanism for collecting cash. So those processes have to be adjusted some. But there is a wave of acceptance, maybe through force of the Transparency Act. They're required to post these. The idea of a lot of the new laws are promoting consumerism with patients. There are opportunities if the providers are required to post the information, then they're going to need to come up with processes to accept it as well. And so if they're able to avoid the insurance process and feel like they're doing so lawfully and consistently, then I think we're going to see more popularity in it as we advance. So I don't think it's all related to RBP. I think a lot of it's just the environment of the healthcare system. They're very highly regulated. And in a way that the average person doesn't even appreciate, right? They're constantly worried about anti-kickback and any sort of payment acceptance that could put them at risk. And so they've created processes that they feel comfortable with interacting with insurance. They have these really complex network contracts that they have to comply with. They can't discriminate against patients. They have financial policies. There is a whole world that does create complexities for them. But the Transparency Act has really opened up an opportunity for those conversations to become easier for providers to adapt. They're just not as fast to adapt because they're slow moving for good reason a lot of times.
Right. I think there's definitely a financial reason. I also think there's just a size reason, right? Like the bigger the building, we always say the bigger the building, the bigger the bill, but also the slower to change.
Yeah. And just like any large corporation, there's more layers, more approvals.
More bureaucracy.
Exactly. And again, they're trying to protect themselves. Sometimes I think those stances to protect themselves are at the consequence of the patient experience, which I think every provider and hospital would agree that the patient experience is number one, the patient care and the patient experience. So any sort of resistance to non-traditional insurance is now overlapping with these opportunities for consumerism, and they should be seen as running in the same lane as opposed to being adversarial to each other. But we are seeing that quite a bit still, and that's why MedCash became such a great solution.
Yeah, and I think it's so interesting, too, you use the word consumerism, how we keep watching consumerism manifest itself differently. Like HSAs was going to be how we were going to get people to be better consumers. And I do hope transparency helps make the American public better consumers. We'll find out, right?
Well, and I read something the other day, and I'd love to give credit to whoever the author was, but it was pushback on the idea of consumerism. We don't shop for healthcare. You don't shop for healthcare the way you do a car or
it's an emotional decision.
A retail situation. And so we shouldn't treat it exactly like that. But that doesn't mean that when healthcare costs are crippling to the American family, we shouldn't help educate them and give them opportunities to make it more affordable. That's what RBP does, and that's what, the cash pay solution may do as well.
Yeah, I recently, and by recently I mean in the last year or so, went and toured a facility in Indianapolis called Wellbridge Surgical, and they do surgical procedures of all kinds, orthopedic, all over the gamut. They're a freestanding facility. They don't take insurance. I believe they just recently accepted reimbursement at their set rate, maybe from United Healthcare, which I found interesting. But they are the second surgical facility in the country to list all of the surgeries, and here's exactly what it costs all in. There's no room fee, there's no anything. This is all in what it costs. And I remember being flabbergasted that they were the second. The first one's out in Oklahoma.
Pioneers. Yes. It is amazing that it is so difficult to come up with a price. And that's probably one of the reasons that you don't often see cash pay options for more complex procedures. But now with good faith estimates and other regulations that force, again, the provider to be able to come up with a cost, it's opening up the cash pay option or that self-pay discount for procedures other than, the simple office visits or imaging, things that are just very easy to price. But yes, it's interesting that is a new concept still to
Novel.
this day.
Novel. Yeah, they just opened a few years ago. And after years and years of collaborating on this idea. Leah, I'd be curious to hear from your perspective because you're sitting in a different seat than Amy or I. And we talked about this the other day. I appreciate that we're all sitting at 3 different seats looking at the same thing. What do you think, based on kind of what you've experienced, cash pay will look like in the next 5-10 years? Do you think we're looking at an uptick, or do you think, what are your thoughts around it? If you just pretended you had a crystal ball, what do you think?
If I had a crystal ball, I think, especially if they're giving hefty discounts from what they're originally billing, I think it's a good thing. From what I've seen from the cases that I've assisted with, the self-pay discounts are insane. It makes your mouth drop almost every single time just seeing them. Once you provide that education to the member, why the self-pay is so much different and way less, then they're almost on board with it. And they're like, yeah, let's do that. That is saving me and it's amazing. So I hope in the future it continues to grow and offers the discounts to the members who may not have access to the care that they need.
Yeah. Yeah, absolutely. I would like to say that I think it's going to become more prevalent. I worry a little bit about the systemic acceptance of it, just having gone through what we went through on a couple clients where seeing it in practice, we realize how much obstructionism is out there for it. So I'm hopeful that there don't become these systemic boulders that make it almost completely extinct. But I do think that we're going to start seeing, especially with the transparency law, and particularly if we get some more teeth in the actual execution and upholding of the law, that we'll see more and more facilities get into it.
I think that we're going to continue to have issues so long as the network environment doesn't allow for some sort of cash pay opportunity for members, which doesn't apply to our plans, right? That's one of the beauties of being open-minded, flexible, and putting the participants and the assets first, is that we aren't stuck with these contract agreements that really don't have the interest of the plan or the participants in mind. And that's really what's keeping this from moving forward. Access to the cash pay pricing, though, is going to continue to grow unless the transparency law is reversed. Yeah. So, if you're open to non-traditional options and willing to step away from the network environment, I think it's going to continue to be a good opportunity for employers and patients. But there has to be some sort of unity between cash pay opportunities that benefit patients and their network arrangements. And that's really what the obstacle is today. And I don't necessarily see that changing overnight. So.
Fair enough. One more question for you, Amy. So hypothetically, I've thought about this a few times. Say hypothetically, I'm a plan sponsor and I listen to this podcast and I am made aware that cash pay can be 50 to 70% off. And it varies based on system and geography. That was just one example. But I catch wind of this. What's keeping me from saying, okay, employees. Now we are cash pay only, and we're going to use plan assets. We're going to store them like we have before. We're going to collect them from you. And now I'm using my claims fund to cash pay everything. We actually don't even have a plan document. We don't have parameters. What are the dangers of that? Why would I not do that?
I don't think you'd have to throw out the plan document. Again, the benefits, the details around that, the reasonableness of pricing and managing the assets is between the employer and the employee. Again, the only way you bring in that healthcare provider is through that assignment of benefit.
AOB.
It becomes so automatic that it just, as a patient, it feels like it should always come from the insurance. I think that model, although I think the most difficult part of that would be member acceptance, because we're just so accustomed to, I have insurance.
Network. Yeah.
I pay premiums from my paycheck, and I just want my claims to be paid by insurance.
Yeah.
And really needing to educate members on what that would look like is that it is an arrangement between the employee and the employer. So if the approach is, hey, you're not going to have an ID card, and you are going to receive a copy of your claim and submit it to us for payment, that's kind of that model that you're describing.
Mm-hmm.
But you have to have a mechanism to pay those high dollar claims, right? You have a lot of employees, or even $100 claim. You have some employees that may not have the ability to pay that up front. And so you'll have to have some sort of funding mechanism. What are you going to give your employees to actually make the payment? And that's what we created, right, behind the scenes here. But a lot of those other cash pay solutions that load a card, you're typically not going to load a $50,000 claim up front. So there has to be a vetting. There has to be service around it, especially for more catastrophic either events or conditions. And so I think the simplicity of cash pay in office environment, the simple services that are very easy to price would not be difficult to implement. I think it's those higher dollar situations that need to have a bit more structure involved. Mm-hmm. I hadn't actually thought about that hypothetical.
I don't know why.
So I feel like I'm on the
brain.
spot to think more about it from like an ERISA perspective.
Like you would still have pre-auth probably. I think you're right. You'd still have a plan document, pre-auth, all that type of thing. I think there'd still have to be lots of parameters. But then also, like, if you loaded a $50,000 card for a surgery, what about processing fees? Like, so that's got to go through a credit card terminal. I don't know. That was just my brain thinking, well, if we love cash pay, like, let's just do full cash pay.
I think that I've heard that in the market. If the cash price is posted, why aren't we just paying cash every time? But as Leah has told us today, and we see time and time again, it's just not that simple.
Right.
Until the healthcare world comes around to truly accepting cash for every patient, then you have to have service surrounding that. And patients can't come up with that money themselves. And so then you're right back to the employer-sponsored plan and what are their parameters for making those payments. You still need consistency. We see it all the time. Oh, cash pay is just a simple solution, and they're just not thinking through the complexities of that. So
that's a great. I do want to jump into that topic too really quickly, because I see this, frankly, on LinkedIn all the time, are people posturing about, well, cash pay, all of these other ancillary solutions are going away. And to your point, like Leah was describing earlier, it's much more complicated, much more complex, lots of people, lots of moving parts, tons of due diligence. So what are some of your rebuttals to this idea of, now that cash pay and AI are here, everything else is irrelevant?
Well, some of the positions of cash pay is the way of the future, and patients just need to pay cash pay, or they need to pay the cash prices. One of those arguments is the belief that the plan should be also paying cash pay, which we've created a solution that allows us access to that. But it really oversimplifies just the everyday use of your insurance and the member's expectations of what that means. I pay premiums into my employer plan. I expect insurance to pay my claims, and now you're telling me I need to cash pay. Those messages are a little bit difficult. Yes, you have some employers, and some of them are our clients, who have been very creative and confident in, we are not going to be beholden to the network environment, and we're going to take control of our spend, and through that it may be some sort of cash pay option. But it's really not that simple. As Leah's explained already today, you've got healthcare providers that if you say you have insurance, push back. You have healthcare providers that may require, even if there is a cash pay price posted, it may be a $50,000 claim. Patients can't just do that on their own. There needs to be service around it. There needs to be assistance in navigating healthcare. And you're going to have some healthcare providers that still want to drive that through insurance. So as much as we would love to see that, a cash pay price on more frequently, if that were the case, then, we'd see the network environment start to fade away. And that's not happening anytime soon.
Yeah, Leah, you see the member side quite frequently. What do you think a member's response would be if, you work through issues every day. What type of member response would you imagine if you said, okay, you have to use AI to look up your rates and now you cash pay?
They would not like it.
They would not.
Yeah, I know. I've worked with members of all ages.
Sure.
And, the younger generation, they're all into the internet and AI, and they would probably be okay doing it. But I know more members that I have worked with than not would not want to do that.
They would feel uncomfortable with the technology.
Yep. Looking at the right things, knowing what to search, how to word it. Mm-hmm.
What's a CPT code and which one is mine?
Yes.
Yeah. And then furthermore, how do I interface with the front desk when someone's giving me resistance?
Yes, how to work it. There's, with the cash pay solutions, a lot of the cases that I've helped with, we type up kind of talking points for the member. If we know that there is that self-pay discount and the provider is kind of giving some pushback, we help that member. We give them some talking points. So that way, if the provider at first turned down submitting to their plan, but then was kind of hesitant on the self-pay because, well, you have insurance, you have coverage, why are you asking the self-pay? Then we provide those talking points to the member so that way they can arm themselves so that way they can get access to that self-pay discount.
Yeah, that's a great point as far as the complexities, not just of how do I access cash pay, but how do I even know what the cash pay price is, right? If the front desk is willing to tell you, which in some situations they are, but not always, then that's great. But this tool or this idea that I can just shop is a little bit more complex than that. If I need some sort of imaging, there's so many different CPT
with contract,
codes.
without,
exactly.
Right. Yeah.
There's just a complexity level there that you still need assistance from experts. And at the end of the day, if you talk to most human resources departments, if you have employees paying premiums in and you ask them to do additional work other than go see their doctor, maybe check to see if their doctor is accepting, or if you're in a network environment, check the network list so you don't go out of network, right? It depends on what kind of plan you are. But if you're asking them to do more work, that's going to be a hard sell. So you need somebody there to really walk them through it and help them so they feel like they're getting that service that they're paying for.
Yeah. Well, ladies, thank you so much for being here. I personally learned more than I realized that I would. Thank you so much, Leah, for taking time out of your busy day serving our clients and giving us some perspective. Thank you again, as always, with your expertise and your legal perspective. We appreciate you being here.
Thank you.
Thank you.
And thank you for being here. We appreciate that. Go ahead and smash the like button. And if you haven't already, please make sure that you subscribe to ClaimTalk on whatever forum that you're listening to us on, whether that's Spotify, Apple Music, YouTube. Make sure you subscribe to ClaimTalk so that you never miss an episode. We drop them every month. Thank you again, ladies, for being here, and look forward to seeing all of us next time.